Hi, welcome to the final segment of my Neoplasia series. In my previous segment, I discussed about the genetic mutations which gives rise to cancer cells. In this segment, I shall mainly be dealing with what causes these genetic mutations, or in other words, carcinogens. A carcinogen is an agent that's known or suspected to cause tumors. All right? An agent that is known or suspected to cause tumors. Now, carcinogens can come in various forms, such as chemical carcinogens, microbial agent carcinogens, which act as carcinogens, also called microbial carcinogens, or physical carcinogens, mostly radiation. All right. So let me start with chemical carcinogens. Now, chemicals can act either directly or indirectly. Now, let me start with the direct acting chemical carcinogens. These do not require metabolic conversion to become carcinogenic, right? So they can directly act on the cells to cause carcinogenesis. For example, alkylating agents. Now, does anybody know what alkylating agents are? They're actually anti-cancer drugs. That's right. An anti-cancer drug causing cancer. You had only one job. Now, how do these alkylating agents work? Well, basically they consist of electron deficient atoms which desperately want to leech off electrons from anything, right? Now, DNA happens to have atoms which are rich in electrons, right? When you look at the carbon, sugar, phosphate structure and the nucleotide base pairs, all of them put together, that's a lot of electrons put together in one place, right? So now when these alkylating agents leach electrons off these atoms, it causes genetic instability. As a result, the entire cell will fall apart, right? It causes quick and swift damage to cells. So in theory, that was why alkylating agents are used for treating cancer. In this case, they're mostly used for treating leukemias. But because of the mechanism of action, they often have an adverse effect, that is, causing solid and hematological malignancies, right? And now moving on to indirect acting chemical carcinogens, they're also called procarcinogens. That's because they directly do not act. They basically they're in an inactive metabolite stage, and they get converted to form an active metabolite, and that's when they act. So the activated metabolite, for example, polycyclic hydrocarbons. What exactly are polycyclic hydrocarbons? Where are they found? They're actually the tar which you find in cigarettes, in tobacco. Tobacco contains 350 to 400 different compounds which are dangerous, one of them being tar. When tar, under high combustion, extreme high combustion of tar and cigarette smoke, forms polycyclic hydrocarbons, right? Now, how do they act? Basically, they get metabolized by cytochrome P450 in the body to form these highly electrophilic epoxides, which then react with different proteins and nucleic acids in the path. And as a result, they can cause malignancies, particularly in the lungs, skin, soft tissues, and breast, right? So as a result, they cause carcinoma in these four places. Actually, anywhere, but mostly these four places. That's lung, breast, soft tissues, and skin, right? So that was cigarette smoke, how it acts. And other forms of procarcinogens also include aromatic amines and azodyes, which is used in the tannery industry, the dyeing industry, textile industry, and heavy metals, right? So these azodyes and aromatic amines, they get metabolized in the liver. You see, the body has a foolproof method for toxins that's known as the conjugation system, the conjugative pathway in the liver. That's mostly glucuronic acid. So that conjugates all these metabolites, that's azodyes, and makes it water soluble. So it's easy to excrete it out of the body. Unfortunately, as it's getting excreted out in the form of urine from the body, it encounters an enzyme that naturally occurs in the urinary tract called as glucuronidase enzyme. And as a result, the metabolite is then exposed back to its normal toxic state in the bladder, hence causing bladder cancer, right? Bladder carcinoma. So that was one other type of indirect chemical carcinogen. Other types also include animal fats. Now, a lot of them are generally saturated animal fats, which can actually break down to form free radicals, which is again highly carcinogenic. And same thing goes with smoked meats. Smoked meats are often used for preservation of meats, where they're treated with nitrates, and these also can tend to cause cancer. Right? So that's chemical carcinogens. Now, moving on to microbial agents or microbial carcinogenesis. Now, what microbes can possibly cause cancer, right? So you have bacterial, you have viral, you have fungal, and parasitic. That's pretty much one from every single major group in microbiology. Now, let me first start with the oncogenic viruses, right? Viruses which can cause cancer. So you can have DNA viruses causing cancer and RNA viruses causing cancer. Amongst DNA viruses, you have human papilloma virus. This can cause cervical cancer. You have Epstein-Barr virus, which can cause Burkitt's lymphoma. You have hepatitis B virus, which can cause hepatocellular carcinoma. That's obviously because of, due to cirrhosis and all that, all the changes in inflammation to the liver and the constant scarring, constant regeneration as a result puts a lot of strain on the liver. So that's why it can cause hepatocellular carcinoma. Right? And there's HHV8, human herpes viridae 8, which causes Kaposi sarcoma. Right? That's DNA viruses. Now, moving on to RNA viruses, the two RNA viruses which can commonly cause carcinogenesis. One is hepatitis C virus, which, much like hepatitis B virus, can cause carcinogenesis for similar reasons. And then there's HTLV1. Right? This tends to target T lymphocytes through this series of steps, the following as it goes. The HTLV1 virus, it integrates with host DNA and produces the TAX gene. Right? Now, this TAX gene inhibits p53 gene, and it also releases a type of growth factor, which is a granulocyte macrophage colony stimulating factor, also called GMCSV. Right? Now, this GMCSV, it promotes T cell mitogens from macrophages to cause polyclonal proliferation of CD T cells. Now, these CD T cells aren't fully mature. They're just randomly and rapidly multiplying. So, as a result, you find neoplasms of T cells. So that's the whole point of HTLV1 virus, right? So, I forgot to mention one thing. RNA viruses, they love integrating with the host DNA, right? They tend to produce their mRNA, which then through reverse transcription produces these proteins, which is how they act. They're oncogenes. This is how they act. Whereas DNA viruses directly integrate with the host DNA, and it churns out its own oncoproteins or oncogenes, whichever one you want to call it. Let's say oncoproteins, for it to act out. Right? So that's how viruses tend to work. And now moving on to bacterial. Now, most common bacteria to cause oncogenesis is H. pylori. Helicobacter pylori bacteria commonly causes gastric carcinoma, mostly maltoma, where it generally affects the lymphoid tissue surrounding the stomach. All right, and there's 4 stages of transformation into gastric carcinoma. There's at least 3 different types of classifications you have to know. I used the Japanese one because it was the easiest to remember during my second year. But yeah, moving on to back to H. pylori. So basically, when H. pylori latches onto the gastric mucosa, it constantly causes ulceration and increased acidity around this gastric lining. So the constant rupturing promotes oncogenesis, and generally, because of the deep permeations, it can also cause maltoma, which is what affects lymphoid tissue. All right, so it's H. pylori. And here's a fun fact: back in the 1950s. Dr. Barry J. Marshall, when he first postulated that H. pylori can cause gastric cancer, first of all gastric ulcers and then gastric cancer, nobody believed him. So how did he prove his point? He ended up swallowing several vials containing H. pylori, and for the next couple of days he had severe gastric cancer. He had severe acidity. As a result, he had gastric ulcers. That was when people actually started to believe him. And that was when he could prove that H. pylori causes gastric ulcers and eventually gastric carcinoma. And eventually he got the Nobel Prize for medicine. Sorry for the deviation, it keeps happening to me. Okay, now another example of a microbe which can cause cancer is fungal. Under that, it's Aspergillus flavus. Aspergillus flavus, in particular, also releases something called as aflatoxin. Now, aflatoxin in general is a very potent toxin and immediately affects the liver. And over time, the certain concentration of aflatoxin can induce hepatocellular carcinoma. Right? Now, moving on to parasites. Apart from an excellent example of a parasite which can cause cancer is schistosoma. Schistosoma hematobium. The eggs of schistosoma hematobium tend to get, when they get excreted out from the body, they generally get lodged in the urinary bladder. And as a result, because they're irritant in nature, the shells of these eggs, they irritate the mucosa around the place and they tend to cause bladder cancer. All right. And another example of a parasite which can cause carcinogenesis is Clonorchis sinensis, which you might probably know as the Chinese liver fluke. And this once again causes hepatocellular carcinoma. Right. Over here, I discussed how HHV8 can cause Kaposi sarcoma. So HHV8 basically encodes for proteins which inhibits P53 gene and the RB gene in one shot, right? And it decreases production of MHC1. The components of MHC1, which I think you probably might know for the graft versus host reactions and all that. So I identify foreign bodies, stuff like that. So as a result, it escapes recognition by the cytotoxic T lymphocytes. It's pretty smart. And as a result, because it evades detection, it can go on proliferating and then result in Kaposi sarcoma. Alright? And over here, I've explained how Epstein-Barr virus infections can cause Hodgkin's lymphoma. It's actually a pretty vague pathway, and this isn't entirely properly understood. But this is one hypothesis which is commonly accepted. So the Epstein-Barr virus infection infects B cell lymphocytes through the CD21 receptor, right? So now it can either cause a productive infection, and then it can cause a latent infection, right? So it's that latent infection which causes B cell proliferation, right? Now, it can either cause immunodeficiency or immunocompetency, two different states. Now, with immunodeficiency, there's immortalization of these cells, of these rapidly proliferating B cells, because there's nothing to keep it in check. So when there's uncoordinated, uncontrolled cell replication of these B cells, it causes Epstein-Barr virus associated neoplasm. And now in an immunocompetent state, there's activation of cytotoxic T cells, which has a feedback loop with polyclonal B cell activation, because the B cell proliferation causes polyclonal B cell activation, and all these can possibly trigger the cytotoxic T cell activation. And so as a result, there's killing of B cells by cytotoxic T cells. Then later on, when that decreases, it has an inhibitory effect on the polyclonal B cell. And the polyclonal B cells, when it gets activated by itself without T cells killing them, can cause infectious mononucleosis. All right. Okay, let's see. Aspergillus flavus, aflatoxin B1. Yeah, it's a potent carcinogen. Then this is why you should probably avoid canned peanuts and canned meats. H. pylori causes chronic inflammation, or gastritis. There's gastric atrophy, then metaplasia, dysplasia, and cancer. Right? And basically, it has something called a CAG-A gene, which enables it to penetrate the gastric epithelium cells, and then it produces its own signals for unregulated growth. Right? Pretty smart bacteria. Now, moving on to more physical carcinogens, particularly radiation. So, radiation in general can cause malignant melanoma, basal cell carcinoma, or squamous cell carcinoma, and can be affected also with UV radiation, which can cause these superficial skin-based manifestations. Or there's ionizing radiation. The action of ionizing radiation can potentially cause leukemias or skin carcinomas. All right? That's why you should generally avoid ultraviolet radiation, especially during morning time, ultraviolet A. All right? And the radiation generally has a long latent period and accumulative effect. So multiple exposures of radiation, even if it's short term, as long as it's multiple, like in a radiologist, it increases their chances of oncogenesis. Right? So how does radiation act? Now let's look at UV radiation and ionizing radiation. So in case of UV radiation, you have pyrimidine dimers in DNA, which is getting inhibited. Whereas with ionizing radiation, there's hydroxy free radicals, which causes injury to DNA. All right. Now let's look at now that we're done with carcinogenesis, let's look at laboratory diagnosis. How do you diagnose cancer from a lab perspective? First of all, there's imaging, or that you can have your X-rays, your MRIs, and your CTs. And of late, the latest one is PET scans, and you can also use ultrasound from the OPD perspective. Now, let's look at morphological methods. One is histopathological examination through biopsy. FNACs are no longer used for cytological examination. Even if it's exfoliative, it's very, very rare. Now it's just open or true cut biopsies, right? Then there's also histochemical and cytochemical staining. Now, for example, the FAB classification of leukemias also includes histochemical staining properties, right? So this can also be used for detecting, the properties of these cells can be used for detecting what kind of neoplasm it is. And then you have immunohistochemical stains, right? Or immunohistochemical reactions, such as the antigen-antibody reactions, or categorized undifferentiated carcinomas, or the origin of polydifferentiated cancers, right? And this in general can determine the prognosis and treatment, right? Now you have something also called as tumor markers, right? So tumor markers helps with detection and effectiveness of treatment or any recurrence, potential recurrence. An example of a tumor marker is the PSA, that's prostate specific antigen. It's generally an indicator of any prostate involvement, whether it's infection of prostate or if it's malignancy of prostate. All right, that's tumor markers. Then another form of lab diagnosis is molecular diagnosis. So it's used for diagnostic purposes, prognostic purposes, and you generally check for hereditary predisposition, and that's when you can make a therapeutic decision to see if whether some patients can react well to certain drugs or for certain procedures. Yeah, so that's when molecular diagnosis generally comes in handy. All right. Now, moving on to the clinical aspects of neoplasia. What makes it so important? Apart from the fatality, what makes it so important? Why should you treat it immediately? One is local effects. It can cause compression. Suppose it compresses an artery and cuts off blood supply to an important structure. Suppose it causes mechanical obstruction, for example, in the GIT. If it obstructs the entire bowel lumen, it can cause bowel perforation and then peritonitis and all other resulting complications. Then there's endocrine insufficiencies. For one, suppose the invading cells overtakes that of a normally functioning endocrine cell, then the overall function of that normal producing cell goes down, so that there won't be as much hormone being produced naturally. That's one, right? Another one is paraneoplastic syndrome, which I shall discuss soon later on. And other local effects can include ulceration, bleeding, and secondary infections, because the local immune response and the healing response is generally impaired. So that's why you find ulceration, bleeding, and secondary infections. And then you find rupture or infarcting of the tumor. When that ruptures or it gets infarcted, basically not only can it potentially cause cutting off of blood supply to the heart, when it ruptures, more cells can spread out and spread to other parts of the body, right? Now, moving on to the functional effects. One is the hormonal effects, such as in endocrine glands. For the most part, if it's a well-differentiated tumor of the endocrine gland, then a lot of the effect is still retained, so it can still be useful. Another one is paraneoplastic syndrome. And then another functional effect is fever. Fever is typically a common diagnostic feature of a lot of malignancies, right? This is largely because of excessive secretions of interleukin-1 and pyrogens. So also it's the type of fever which you get with malignancies. It's often pathognomic for certain types of conditions, and It's exclusively used for diagnosing these conditions. There's Hodgkin's lymphoma, right? That's when you get Pelebstine fever. Then you have renal cell carcinoma, where during metastasis through a hematogenous route causes increased fever. And then there's osteogenic sarcoma. Because of subsequent inflammation of the surrounding necrotizing tissue, there is fever involved. All right. Now, moving on to something known as tumor lysis syndrome. So basically, the products or tumor cells, when they break down over time, largely because of chemotherapy, they release the products, right? So this can include metabolites such as electrolytes or urea. So you find them accumulating in the body because people don't have anywhere else to go to flush these away, right? So for example, you have hyperuricemia, hyperkalemia, hyperphosphatemia, hypocalcemia, lactic acidosis, and hyperuricemia. Right? Let me repeat it one more time. Hyperuricemia, hyperkalemia, hyperphosphatemia, hypocalcemia, lactic acidosis, and hyperuricemia. Right? So when cells generally break down because of chemo, they tend to release these products. In this case, it's urine. Sorry, why am I saying urine? In this case, it's urea. Here, it's potassium. Here, it's phosphate. Here, it's calcium. Here, it's lactic acid. And here again, it's uric acid, sorry. Uric acid, my bad. Right, so it's tumor lysis syndrome. And then you have cachexia. This is most commonly seen in later stages of cancer, and it's also a serious complication, which is why you should act fast to prevent as much wasting as possible, right? So it's progressive weight loss with severe weakness, anorexia, and anemia in cancer patients, right? Cachexia is progressive weight loss with severe weakness, anorexia, and anemia in cancer patients, right? So it's often because of the release of cytokines such as TNF-alpha, interleukin-1, and interferon gamma, right? So when cytokines such as these get, sorry, what was I saying? Yeah, so when cytokines like these get released from cells, that's what triggers all these symptoms, right? So that's cachexia. Now, moving on to paraneoplastic syndromes. This is actually an important topic, but clinically you will rarely see this. If you ever find a really complex case, you must not always suspect paraneoplastic syndromes. That should be the last thing you should ever think of. It's pretty rare, right, in the general population. Not amongst cancer patients, but in the general population it's rare. So paraneoplastic syndrome is basically when you find hormones being produced from one part of a body, which is typically not seen in that part of the body and should come from another side, right? So, for example, the first manifestation, what makes it so significant is that the first manifestation of an occult neoplasm. It can be mistaken for metastasis, can be often fatal based on the hormone being released, and monitoring recurrence in patients is absolutely essential, right? And inappropriate treatment can also be derived based on the mistaken for metastasis part. If you're not treating the paraneoplastic syndrome properly, it can cause other complications. So paraneoplastic syndrome, it's seen 10 to 15 patients, cancer patients, and symptom complexes are seen in cancer patients. It's not related to metastasis, selection of hormones, which are typically not indigenous to the tissue of origin, right? So examples include Cushing's syndrome, which can be seen from small cell carcinoma of lungs. Cushing syndrome-like symptoms can be seen because of excess secretion of ACTH hormone from the small cell carcinoma of lungs. Then you find hypoglycemia, where insulin is being secreted by fibrosarcomas, right? So these two can generally have a lot of endocrine complications. And then you find renal cell carcinomas secreting erythropoietin, so it causes polycythemia. And then you find multiple myeloma causing amyloidosis because there's increased deposition of the Bence-Jones protein, right? Paraneoplastic syndrome. Now let's look at the prognosis. This is most important when you're dealing with cancer. So one is when you're looking at the histological type, you have to grade the malignant tumors using TNM staging. This is most commonly used, and it's used for 5 different types of cancers. Mostly, for example, it's used for breast, thyroid, for example. Now, T and M stands for something. Okay, the T stands for tumor or the status of the tumor, N for the lymph node, and M for metastasis. All right. So for T, you look at the size of the primary tumor. For N, you look at lymph node status, and for M, you look at the metastasis. All right. So based on that, you can grade it out based on what is it, TX, T1, T2, T3, and all that. You have to add it up, and then if you have to score it, if it comes above certain index, it means action should be taken, definitely. If it's below that, then, well, it should be a milder course of action. All right? And that, folks, concludes the end of my series on neoplasia. I'm sure you probably have doubts in this segment as well. Please feel free to ask me doubts anytime. You can text me, call me, or ask me in person. I'm open to answering your doubts anytime. Thank you. Goodbye. I hope you enjoy my series.